Good afternoon and welcome to Bariatric Friday. My name is Dr.Irgau. I'm the chairman of American Surgery Center. I'm here with Dr. Irgau, our program director. Dr. Irgau, how are you doing?
I'm doing great, Kamal. It's great to be back on yet another session of Bariatric Friday.
It's always great to have you. And also today we actually added a new topic. As many people know, we have specific topics that we discuss, and there is a cycle almost. So there's 13, 14 of them. So we, as we feel necessary time to time, we add new items. And today we want to discuss treatment on morbid obesity and the different options that we already know, but also some of them may get a little bit more popular just because of the publicity and what we see in media, and also some part of this is just a perception. So weight loss drugs is what I'm talking about. We take morbid obesity extremely seriously, and as we always mention, what's the most effective, efficient tool to fight morbid obesity? When it comes to that, it is the bariatric surgery. Now, the other thing is many people still struggle today is how much do I need to lose? Where am I with my BMI? Can I just do this by dieting, by walking more, by doing X, Y, Z? All those things we discuss, and we make sure that this is a resource for those individuals who are having these types of issues. Now, concern that we see with weight loss drugs, although on one hand, it's great that industry is understanding this is a disease just like diabetes. And how to treat and manage is going to require the best team and also going through the best options and most effective options. Dr. Irgau, I have some questions later on, but I want you to kind of tell us your perspective of these issues, and then we can go into the questions.
Absolutely. In general, Kamal, if you look at the history of surgery, right? Any type of surgery. We do an intervention where we actually, as surgeons, are invading the body, right? To under treatment, right? So there has always been a desire, and rightly so, from medicine to try to find a way of addressing the treatment without invading the human body, right? So rather than doing surgery, for instance, to fix an ulcer in the stomach, medicine evolved to find medications that can do exactly the same thing without the surgery itself. So whenever there are medications that come up to replace surgery, it's a triumph. There is no question about that, right? So when we undertook surgery to treat morbid obesity, when my predecessors, when the first pioneers of bariatric surgery were doing surgery to address this problem, is because they saw the desperation of morbidly obese patients, and there was no option at all for those patients to have any type of treatment outside of surgery. So they came up with surgical procedures that over time evolved into becoming very effective, very safe, and undertaken really in the most minimalist fashion, whereby we would enter the abdomen or the inside of the body with very small incisions. And we're undertaking these complex procedures now in situations where patients come in the morning and we send them home the same day, right? So surgery has achieved that level of safety and quality that made the surgery even more acceptable to more people. And yet we still want to see if there are medications that can do the same thing. So this attempt at finding medications has a long history. Having said that, the medications that we've seen over the years, either they were not effective or they had too many side effects so that they really couldn't match up to what surgery was doing. Now, more recently, we are seeing medications that are much more robust compared to the previous generations, right? So we see even more enthusiasm now about, well, maybe we can use medications as opposed to surgery. When we delve deeply into the medications that we have right now, Kamal, yes, they are very strong. Yes, they are much more powerful compared to the medications we used to have in the past, but still their effectiveness is nowhere near the effectiveness of bariatric surgery in terms of the actual results that we see with the weight loss in the duration of the result itself, right? So my perspective on this, Kamal, is that I very much welcome any type of treatment that will advance the cause of treating obesity, right? Not only because obesity is such an entrenched disease that sometimes is even resistant to surgery as well. So addition of medication may be something that we have to do, right? But there is another side, which I think is much more important, Kamal, and that is the addition of stronger medications will actually expand, right, the understanding in our society that obesity is indeed a disease, right? Because until now, and still we are fighting with this notion that obesity is a lifestyle issue. Obesity is something that somebody can take care of, right? But once you start getting more and more people accepting, for instance, medication as a treatment of obesity, that fact by itself is leading us to believe that obesity is indeed a disease. So unlike some people who say, well, these medications may decrease the rate of bariatric surgery, I actually think it will increase the rate of bariatric surgery because it will expand this knowledge into our society that this is not a lifestyle issue. The obesity is not a choice a person makes. Obesity is a disease, just like diabetes, just like high blood pressure. And by choosing medication, actually, we are now legitimizing the fact that obesity is indeed a disease, a notion that is now relegated only within the healthcare profession, but society at large now can accept this fact, can accept the fact that somebody should go to their doctor to get treatment for obesity, right? So I think actually it's a good thing. It's a very important thing actually that we have medications that are this powerful.
I think you and I, we are on the same page, and the reason we want to discuss this is not because how you and I we understand this. So one of the things that we do is daily case conferences, and I want to give you a couple of examples. And you and I, we weren't able to spend much time since I was in Turkey, and then this is the first week I'm back. So we didn't actually sit down and discuss some of these things, but we agreed to discuss this topic. So what I see is a patient with 64 BMI, finishing everything, and then saying that, oh, there is this new drug available, so I'm going to stop the process. And I'm like, well, you spent 3-4 months, went through like cardiology, pulmonary, EGD, nutrition classes and all that. Also, the drug is not for you to effectively, efficiently bring this issue down. Yes, it will help you 10, 12, 15%, but your BMI is 64. You have to lose 200 pounds to go to the expected BMI. So losing 30 pounds is not our goal here, right? So then it happened another time. And this time patient didn't start the process and BMI was 69. And I'm like, going back to the square one. So all this time that we spend in these events and other webinars, and when you guys are seeing the patients, explaining people in our ACO meetings what morbid obesity is and the treatment for morbid obesity and how severe it is. Like, that's the part that most people struggle to understand. Again, it's not for you and I to lose 10, 12 pounds and be back to normal. We are talking about losing 150 pounds and safely and effectively and as safely as possible. I'm not going to say as quickly as possible, but as long as it's safe. So then that means, issue of perception and how this it's a really effective drug. In fact, we use these drugs for patients who are going through the surgery because we want them to be at a lower BMI. So there's a special diet that they have to do to shrink the liver a little bit anyway, right? So even that time they lose maybe half of what they would do in 6 months. In 2 weeks, that diet does hit you with 20 pounds. Many of patients are losing. So then again, okay, so did we miss something, or did people miss something? So then usually people are missing stuff. So I want to make sure that we kind of discuss when is the right time, and not just the right time, but how is it an alternative to the surgery is the key. And the answer is no, but I want you to kind of, maybe elaborate in a way that, everyone can understand.
Absolutely. So like any disease process, Kamal, it all has to do with understanding the severity of the disease, right? So when we talk about weight-related, disease, we talk about different degrees of severity of the weight issue, right, Kamal? We talk about somebody being overweight if their body mass index is, between 25 and 30. And then we talk about class 1 obesity if the body mass index is between 30 and 35. We talk about class 2 obesity if the body mass index is between 35 and 40. And then over 40, we talk about morbid obesity, right? The clinically severe obesity. So obviously, the levels of morbid obesity can be variable as well. You can have somebody with a body mass index of 45. You can have somebody with a body mass index of 60, as you say. We see patients even with higher body mass indices than that, right? So the question is, what treatment is appropriate for which body mass index? That would be one question to answer. Clearly, if somebody has class 1 obesity, a body mass index of 32 or 33, Kamal, that patient could do very well with a medication like Ozempic or Wegovy or Mounjaro to get their body mass index within a normal range, and they will achieve that, right? So that would be an appropriate indication. In fact, even before the appearance of these medications, currently, we don't consider somebody with a class 1 obesity as a candidate for weight loss surgery, right? We talk about surgery being appropriate for severe forms of obesity. So traditionally, surgery has been indicated for people who have a body mass index of 40 or over, or sometimes a body mass index greater than 35, but with the development of illnesses like type 2 diabetes, high blood pressure, or sleep apnea. So clearly, the place of medications to induce weight loss would be best suited in places where we are looking for modest weight loss to achieve the results that we wanted. As you correctly said, if you are 210 pounds and you're 5'5" or 5'6", if you were to get a medication that reduces your weight by 30 pounds, that would be a good result. There is no question about that. But if you are 300 pounds, if you are 350 pounds and your body mass index and your height is still 5'5", Kamal, losing 30, 40, or even 60 pounds with the best results that have been reported with medications, you would still be very, very high in your weight, right? If you are 5'5", with an ideal body weight of 150 pounds, but if your current weight is 300 pounds, and let's say you get, the most effective medication right now would be Mounjaro, right? Which has been reported as showing up to 20% weight loss in some patients. Well, with that result, somebody who's 300 pounds would be losing about 60 pounds. If you're 5'5" and lose 60 pounds from 300 pounds, you would still be 240 pounds. Come on, you would be at least 100 pounds away from your ideal body weight, right? So when you look at bariatric surgery, that same person could be losing, double that, up to 100, 120 pounds, which would bring their weight considerably lower. So for somebody who is with that high of obesity, clearly, even with the most effective medications, they would be better off with bariatric surgery. There's no question about that. That is really what the facts are right now. Come on. Having said that, patients may still be reluctant to undergo surgery as the first option, just because, people have different notions about what bariatric surgery may be, but also because they themselves need to be comfortable with the idea of surgery. So even if a patient with a high body mass index, if they are not ready to have surgery, I think it's appropriate for them to still have medications as a way to at least counter what they have right now. Even if they have modest weight loss, it's still better than not. But also it may be protecting them from further weight gain as well. However, there are limitations with medications as well. First of all, you have to be on those medications on a continuous basis. The minute you stop the medications, the weight tends to come back, right? Also, there is tolerance of these medications. People may have side effects related to problems with gastrointestinal symptoms, whether it's intestinal cramps, whether it's nausea and vomiting, or even more serious problems like pancreatitis. They can occur with the medications that may not make it suitable for a person to have those medications. Having said that, there are obviously complications with surgery as well, and we talk about complications in our sessions. The complications of surgery tend to be much more defined, because now we have how much experience we have with weight loss surgery. Come on, 40 years. That's a long time. And bariatric surgery, because it had to go through so much scrutiny to legitimize itself, bariatric surgery is probably one of the most heavily studied disciplines in medicine, right? We had to make it really super safe for us to legitimize the discipline itself, right? So we have 40 years of experience with bariatric surgery, but with the newer medications, we don't have that much knowledge come out. Our knowledge is obviously limited to the periods it takes for the trials to occur. So they have their own place. For modest weight loss, clearly medications will be appropriate. But when you have somebody who's struggling with body mass indices like the one you're mentioning, clearly the most effective treatment that we have remains still bariatric surgery.
So, yes, last night actually, I learned that my BMI is higher than former President Trump's. So you're supposed to be kind of like surprised, Dr.Irgau. So now the reason I'm mentioning this, he self-reported his weight. So his height is. He self-reported when he was.
Oh, okay, yeah. Now I get it. Yes, okay.
So, people know by now that we don't rehearse these things, so you don't know what's coming. So
of course,
when I saw, this is a politic news, but then from selective side of me, I look at the height and weight, and he's apparently my weight, and then he's 2 inches taller. I'm like, President Trump, yes, you can lie about 10 pounds, but you're lying a little bit more than 10 pounds. I mean, I see your dress size, you are at least 40 pounds more than what you are reporting. My point is, we all do this. And why we are doing it is because of the perception of this issue and the social stigma that we discussed before. Even someone who goes to turn himself in with a private jet bigger than the Air Force One and with 300 people escorting him, he lies about his weight. All right, so we all do. And that's why when we bring this issue to see how realistic to utilize certain things, if you lie to me about your weight, and I tell you, I will always probably take 10 pounds, about 10 pounds off from my actual weight until I'm comfortable with where I am. So that means we still have this issue of come to our senses on weight loss, the morbid obesity issue. So my BMI is 28, right? My latest calculation, so I may be a little bit lower than that now because I did lose, since I'm more strict on my diet. That medicine perhaps can be helpful for me to be going down by a couple BMI points. And it can help someone to speed up the process while they're going through bariatric surgery And even after bariatric surgery, right, Dr. Irgau, because some patients do struggle with, not every patient has the same outcome. So we are supporting the idea, and we are happy that the healthcare industry now is more on board for the fight that we are giving for morbid obesity and the treatment option that we have. But it has to be used appropriately so that we are not actually thinking that, oh, no, I can do this instead of that. No, this is why we have this program every week. So I know some of our patients are going to watch this and they're going to be like, oh, they're worried about losing cases. That's not true, because this month we have the second highest month of the last 12 months. So that's not the conversation. That's not the reason for this conversation. It's just like what's right and what's wrong. And or maybe who should make that decision the best, kind of like is the main point. Now, the cost of this medication also is another issue. It's about $2,400 a month. And this is a first-hand knowledge because of our primary care business. We have to kind of go through this because insurers are saying that, well, have you done X, Y, Z? What did this patient go through? Because this is an expensive drug, and it's going to take several months to fix the issue first. And it's going to be at the level, maybe it's going to be 15 to 20% max. Actually, 17% is the max. But if my BMI is 64, what's 17% to me?
Yeah,
I'm still going to be like 57 BMI. So that's why people need to kind of separate the issues. Again, just like, we use the intermittent diet as a sub-tool of, getting the patient ready for the surgery. So this is another one. And for those patients who are never going to have surgery, they should work with their primary care and maybe bariatricians, nutritionists. And I can tell you, without a nutritionist, nothing works. So, because we did that mock session in July, you can tell, even for us, we pick up stuff from the discussion. So there's no magic in healthcare. So just like we always said, bariatric surgery is not a magical tool either. It's a very powerful tool, but it's not magical. So if you don't follow through the things that we give you pre-surgical and post-surgical, chances are you may fail. So, so that's why when we look at these things, don't waste the progress that you have in the process that you are going through for the bariatric surgery and say, well, I'm going to delay this for another 12 months. So you'll come back with another 50 pounds. And because this is not going to work by itself. Again, it's today we were actually just doing one of our write-ups for bariatric program. And we always, mentioned this multidisciplinary approach. So it's not just the surgeon, but everyone in other specialties who work with the surgeon through the process is making the bariatric surgery successful. So the PCP, primary care, giving you this drug, and you have other comorbidities and not looking at the side effects, and or taking that risk of those side effects, and then just expect to lose 20 BMI points, ain't gonna happen. So, and that's not what they're promising anyway. So, but we are happy that at least there's a better awareness of this issue from the morbid obesity standpoint, the treatment for morbid obesity standpoint.
Absolutely, absolutely. If you remember, one of the interesting lectures that you and I attended was, I believe it was in Houston or in Austin, Texas. Austin, was it, or was it in Houston? I don't remember. One of those places. We went to a conference many years ago.
We went to
many years ago, and there was this professor from Boston who said, "How could a primary care physician see a patient year after year, seeing them with go from a BMI of 38 to 40 to 42 to 44 to 46 and so forth, and never discuss the weight issue, right? That was one of the, it was telling for us to hear that, because obviously that was a problem many years ago, right? There is more awareness now, right? But one of the reasons perhaps primary care doctors were reluctant to pursue this issue was because perhaps they felt powerless beyond something like bariatric surgery, right? When they talk to their patients, because they knew that just telling the patients go ahead, diet and exercise wouldn't give the results, because obesity is such a complex disease that every time you try to reduce your caloric intake and increase your energy expenditure, the body just puts in action regulatory mechanisms that protect that weight. And so that battle becomes really very, very hard to win, right? So doctors felt powerless, but with the advent now of more medications that they could prescribe in their offices, with the understanding of the limitation of these medications, I think there will be more conversations between the primary care physicians and their patients about obesity, because they will be able to give them more options and choices, right? But at the same token, obviously, the understanding that more severe forms of obesity may not be responsive to this medication in an optimal fashion. If you have somebody who needs to lose, as you said, 100, 120, 130 pounds for them to be within a healthy profile, then clearly bariatric surgery is going to be the option that they will have to look to. But at least the conversation will start. I think that is important. Another thing that is very important from the complexity of obesity, Kamal, is that obesity sometimes is so resistant that even surgery, successful surgery, may not have a major dent on it. And we see that with some of our patients, which may not respond optimally to some procedures, and very often we look for different procedures. It's called revisional surgery. But at this stage, maybe adding medications to patients, like you mentioned earlier on, may be a good idea. So now we're looking, understanding that not only obesity is a disease, but it's a complex disease, and it's okay to tackle a complex disease with different treatment approaches. So surgery could be potentially combined with medications to get the best result in some patients, right? Just like many other diseases. For instance, there are many cancers now, Kamal, that are treated not just with surgery, but with surgery and medications, with surgery, medications, and radiation therapy. Why? Because attacking them from different angles can give us the best success. Similarly, we have to start thinking about obesity as something that may require surgery, will require lifestyle changes, and may require medications as well. And this approach will lead us to really establishing the success that we're looking for.
So, Dr. Irgau, the way that when you were explaining this, on the Economic Care Organization, we also do case conferences there. And part of the form that we have, we duplicate everything that we have in this chart on our database. And then it's a little bit more user-friendly to see the medications than altogether. And patient who may have diabetes, they require more than one medication in many cases. So, and then as the way that they are doing, they have to go up from the, if it's not controlled with one medication, they go to the second level and then they add another one. But there are some cases they have 4 or 5 different things that they are using. And when they have to use more than 2 medications for diabetes, 97% of the time they have 2 other comorbidities. So that gives you another 1 or 2 drugs. If you remember just this week, I don't know if you were there for that day, there was a kind of like surprising result from the TSH level standpoint, because the patient was on 2 different medications, and TSH was going down first, and then it went up again because the other medication was affecting the efficiency of the first one. So, well, the only reason I knew that is because I had to call our pharmacist in the ACO and ask her if she could just look at the chart and see if there are any issues. So, when this is a very complex issue, And then when you add the comorbidity of to those, if we are the comorbidity, morbid obesity, but for us, if they would be the comorbidity, it's a very complex situation. So, and if we don't actually really understand if you don't have a good plan, and who's going to do what in this plan, what everyone's role is, what outcome we are looking for, we cannot expect this from one. It's not an alternative to the one to the other. It is just, the combination of right things together.
Yeah.
So that was kind of like our goal for today, to instead of for our surgeons to discuss some of these one by one. So sometimes we send these linked to the patients for extra support. So hopefully they can find this useful. So we'll be back next week with another episode, another topic. I don't know if you want to add anything before we close.
No, I think what I want to add is, that anything that will improve the awareness that obesity is a disease is really welcome. Anything that helps us tackle obesity, such a complex condition, in a safe manner is really welcome. So the more, the more tools we have to tackle the problem, the better it is for us. But we, as you correctly said, we have to know when to apply a specific tool in what condition. And clearly, when it comes to really severe obesity, bariatric surgery still remains the most effective treatment we currently have available.
For those out there who want to become most knowledgeable, follow us, watch us. There are so many things already out there. We have posted all of them. There will be more. So this is the place to learn how to fight most effectively, most efficiently with morbid obesity, and don't listen to anyone other than the experts. So we'll be back next week.